Thank you for inviting me to BAUS. It's a real honor to present in this debate about whether Optilume is the new dawn for endoscopic stricture management. I'm Sean Elliott, and I'm a urologist in the United States. I'm also the principal investigator of the device under discussion here, the Optilume, which is a drug-coated balloon for the treatment of urethral stricture. So as the principal investigator, I have some funding to conduct this study. I do not stand to gain anything personally, financially. I'm also a consultant for Boston Scientific. So what is the critical need for Optilume in today's environment? Historically, we know that DVIU and dilation do not provide durable success. In the classic study by Chris Haynes et al., we see that if a man's had a few previous treatments for urethral stricture endoscopically, his long-term chance of success with another treatment is pretty much nil. So then the question becomes, are there things that men can do to help increase their chance of success? And the answer is yes, you can do a DVIU or dilation and then add in self-dilation. There have been a couple of randomized trials of self-dilation in the past, and when you take the results from these two randomized trials together, you see that urethral dilation after DVIU or dilation performed by the patient themselves will delay the eventual recurrence of the stricture. And the way I get to that is if you look at the study by Kierkegaard et al., the men were randomized to either DVIU or DVIU plus self-dilation for a year. And at the end of that 1 year, the people on dilation had a much higher success rate. But if you look at the other randomized trial, where the men did self-dilation for 3 months and then were assessed for stricture recurrence at a year, you see that the success rates between the two groups are no different. So it seems like as soon as you stop doing the self-dilation, your chance of recurrence is just as high as a man who never did the self-dilation. We know that self-dilation is associated with poor quality of life, and so a lot of men will not opt to do that long term. It's especially associated with a poor quality of life, as shown in this study by Al Mori, when the patient is younger, or they have a more proximal stricture, or if there's any difficulty passing the catheter. Are there other things we can add to DVIU or dilation to help keep the stricture open? Well, yes, there's been about 20 studies, and about half of them are randomized trials of adjunctive therapies done at the time of DVIU or dilation. And Mr. Osman here is actually working on a systematic review of said topic. If we do intermittent self-dilation with a steroid-coated catheter or inject steroids at the same time, it appears to delay the eventual recurrence of the urethral stricture. Mitomycin C injection at the time of DVIU does seem to reduce the risk of the stricture coming back by about half. The studies with intraurethral mitomycin or intraurethral hyaluronic acid are not as strong. Overall, the quality of these studies, even though they're randomized trials, is poor, and the outcomes are variable from one study to the next. The dosing is rather inconsistent from one study to the next. There's a high risk of bias across these studies, and there are some complications with mitomycin C to contend with. I would be a fool not to talk about the OPEN trial when speaking here at BAUS. So the OPEN trial was a randomized trial performed here in the UK for bulbar strictures that had failed at least one prior treatment. Men were randomized to urethroplasty or DVIU, and the primary outcome was a quality of life questionnaire. And the take-home message is that the quality of life improved in all the men with treatment, and the improvement was not different between DVIU and urethroplasty. When you look at the clinical outcomes, however, they did favor urethroplasty. The risk of reintervention after urethroplasty was about half as much as after DVIU, and the flow rate was better after urethroplasty. When you look at a cost effectiveness comparison of this trial and your primary outcome is this quality of life outcome, of course DVIU is going to be favored for cost effectiveness because the price is about half of that of urethroplasty and the quality of life outcomes are similar. The study did not consider the cost of repeat procedures, which could drive up the cost of DVIU or dilation. And it's worthwhile to note that others in the US have shown that DVIU dilation is more cost effective, at least for treatment naive men with a less than 2 centimeter bulbar stricture. But then once you get to repeat treatments or longer strictures, DVIU dilation is not more cost effective. So how do we put all of this together? What are the guidelines? The guidelines from Baggers are really not that different, or the recommendations from Baggers are really not that different from the guidelines from the EAU, the AUA, and the SIU in terms of how we should manage short bulbar strictures. The standard should be that DVIU dilation have good results when used for the first time in short bulbar strictures, and urethroplasty is the only curative option and is more cost effective than repeated endoscopic intervention. And self-dilation can be considered as a palliative maneuver, but is not curative. So that leaves us with the question, are there any alternatives? Because when I present this to men with a urethral stricture, they do ask me, well, doc, isn't there something in between what sounds like a low-risk procedure, DVIU dilation, and urethroplasty, which is scary to them because we're operating on their penis? And right now, we don't have a lot to offer in between. We can do some of the adjunctive therapies that I mentioned earlier, but the data is mixed. And so we have one procedure that's minimally invasive with a low success rate, especially after it fails one time. And then we have another procedure that's more invasive. As surgeons, we see it as not that invasive because the man only stays in hospital for one night, or in some cases goes home the same day. But the men that I talk to generally see this as an invasive procedure, and they worry about possible side effects like erectile dysfunction and ejaculatory dysfunction. So what I'm proposing today is that Optilume may help bridge that gap between DVIU dilation and urethroplasty. So what is the Optilume? It's a paclitaxel drug-coated balloon developed by a company in the United States, right in my backyard in Minnesota, called Urologic. It borrows from the success of drug-coated balloons in coronary angioplasty, and it is similar to the concepts of mitomycin C injection after DVIU. Currently, there's a 30 French balloon and a 24 French balloon. We've favored the 30 French balloon for better outcomes in urethral stricture. It comes in a 3 centimeter length and a 5 centimeter length. The paclitaxel coating helps delay wound healing and hence helps push off fibroblast ingrowth and scar tissue growth. The T1/2 of paclitaxel is 3 to 7 days, which keeps it active during that initial phase of wound healing, but then it disappears and doesn't have any lasting effects is the idea. There's really minimal or no uptake in other tissues, and we've tested that in the clinical trial setting. One of the keys is this concept of an excipient. The excipient is a hydrophilic carrier molecule that helps facilitate the hydrophobic drug paclitaxel to be released from the balloon to the tissue. So again, it seems kind of similar to DVIU plus mitomycin C injection, so I think it's worthwhile to compare those. Some of the theoretical advantages of the Optilume over DVIU plus mitomycin C is that you have a standardization of technique. In this case, everyone is getting a dilation by the same size balloon rather than DVIU, which can vary a bit in technique. There's a standardization of the drug dosing to keep people from delivering very high doses of the drug. And then it standardizes the delivery technique. So it's not all injected in one site, but circumferentially. The balloon also creates multiple microfissures in the tissue versus a few deep cuts, which would happen with a DVIU. So when you combine these concepts of multiple microfissures that are created circumferentially in the urethra, plus circumferential drug delivery, that may promote good prevention of scar tissue formation and may minimize some of the side effects of having too much drug injected in one spot while not having enough in other spots. What I would say, fewer peaks and valleys and more of a smooth drug distribution. And what are the outcomes of the studies of this? So there's basically 3 trials of the robust balloon. The, two of them were single-arm multi-center, and then there's Robust 3, which is a randomized multi-center study. You can see the number of sites involved in the study there. The mean stricture length is generally about 1 to 2 centimeters. Almost all of these strictures are bulbar. The median number of prior dilations is 2 and 4 in the first two studies, and is 3 in both the control arm and the active arm in Robust 3. The etiology of stricture disease is as you would generally expect. There were about 11% of men with previous radiation therapy in Robust 3 and none in the other two studies. The primary outcome in all three of these studies is cystoscopic findings at 6 months, but we are following the men out to 5 years and following secondary outcomes, including IPSS scores and Qmax. So the results from Robust 1, which have been previously published, were really good. We had about 70% 6-month cystoscopic success, and then we also had about 70% success in terms of improvement in IPSS at 1 year and then also at 2 years. So the question is, would these hold up in the randomized trial? And as I'm pleased to show you here for the first time, we do see consistent improvement in IPSS and Qmax in all three studies. So I'm going to show you a few graphs here, and in each case, the notation will be the same. So Robust 3 control arm is here in maroon. Robust 3 intervention arm is here in gold. The gray ones are Robust 1 and 2, which were just single-arm studies. And then in blue, we have Optilume pooled results, which would be pooling the gold and the two gray. And what we see is that the improvements that we saw over 24 to 36 months in IPSS in the Robust 1 and Robust 2 studies are still showing up in the Robust 3 active arm at 12 months. It looks incredibly consistent, and we're not seeing that improvement in the control arm. In fact, their symptoms are returning by 6 to 12 months. Similarly, for Qmax, we see a big improvement in Qmax, and it's sustained over time in the active arm, but not in control. What about the cysto results? Because that's what we all would consider kind of the gold standard. And I'm happy to say that we have consistent cystoscopic success across all three studies, where every one of them had about 75% success with the Optilume drug-coated balloon, whether in Robust 1, 2, or 3. And then the control arm in Robust 3, the success there is about what you would expect. For men who've had 3 previous DVIUs or dilations, their success was 27%, which is really quite similar to the Chris Haynes study here. They would be the men in this highest risk group with 3 previous DVIUs or dilations. How about the outcome of freedom from reintervention? That too is incredibly consistent with excellent freedom from reintervention rates at 12 months in the randomized study and then 24 and 36 months in the non-randomized studies. And you see that the gold active arm is very similar to the Robust 1 and Robust 2. And in the control arm of Robust 3, we see that most men are not free from reintervention after a year. Adverse events. Well, adverse events were not serious. There were no serious adverse events in the Robust 3 randomized trial. Dysuria, hematuria, and pain were more common with Optilume, and I think that's important to note. It's important to note because I think that men have to understand the higher risks, but I think it also pays testament to the fact that this drug is doing something. It's inhibiting the wound healing, and that may be part of the reason that there's more dysuria, prolonged hematuria, because the microfissures that are being created are taking longer to heal up. So here we see higher rates of dysuria and hematuria in the Optilume arm, more pelvic or penile pain. There was one case of urethral cancer, which of course can happen in men with recurrent urethral strictures. So in summary, the Optilume provides an in-between option for men with recurrent bulbar strictures. The success rates are superior to DVIU alone, with mild to moderate adverse events being slightly higher with Optilume. Really, the success rate is 3-fold higher than with standard DVIU or dilation. The one-year randomized trial results are being prepared currently for a manuscript. You can expect to see results through 5 years, including the IPSS and Qmax. Future trials that you can expect to see may include vescourethral anastomotic strictures, or what people commonly call bladder neck contractures after radical prostatectomy. And then here in the UK, there may be a trial funded for DVIU versus DVIU plus mitomycin versus Optilume. And the Optilume is currently approved for use in the UK, the EU, Canada, Israel, and Hong Kong. Thank you.